Hi everyone, good evening, and thank you for joining us for tonight's webinar in partnership with St Vincent's Clinic. My name is Lauren Thomas and I'm CPD Program Officer at Central and Eastern Sydney PHN. I would firstly like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I'd like to recognise their continuing connection to land, water, community, and pay respect to elders past, present, and emerging. And I'd also like to extend that respect to any Aboriginal colleagues who might be joining us tonight. Just some housekeeping for tonight. This session will be recorded and will be available on our YouTube channel within the next few days. There will also be at the end of the webinar an evaluation survey, which will pop up on your screens, and a follow-up email will be sent tomorrow as well. And we'd really appreciate any feedback you have for us. Also for GPs in attendance, we have 1.5 hours of educational activity for RICGP. We will upload those activity hours for you on your behalf. And any questions, please send them through on the Q&A function. With our speakers tonight, we do have the chat open to be a little bit more interactive with the cases. So if you could kindly keep your questions to the Q&A function, and there'll be some questions and a couple of polls throughout. I would now like to introduce Caitlin El-Masri from St. Vincent's, who will be facilitating tonight. Thank you.
Thank you, Lauren. Hi, everyone. My name is Caitlin El-Masri. I am the Marketing and Events Coordinator at St. Vincent's Clinic, and I'm delighted to welcome you to this interactive webinar in partnership with the Central and Eastern PHN. I'd just like to share a bit on St. Vincent's Clinic for those who may not already know. St. Vincent's Clinic is a multidisciplinary clinic of excellence with over 300 specialists practicing across 30 healthcare areas, providing a range of investigative, diagnostic, and therapeutic services for patients referred for healthcare. The clinic is also home to St. Vincent's Clinic Research Foundation, which funds research across the St. Vincent's Darlinghurst campus. And we also have Open Support, which is our community services arm, providing support to women and children escaping domestic violence and individuals across the community experiencing social isolation. If you have any questions for the clinic, please feel free to reach out to me. Now, in tonight's webinar, you will hear from two of our St. Vincent specialists. We have Dr. Kieran Owens, who is a psychiatrist at St. Vincent's Hospital Darlinghurst with special interests in mood disorders, cognitive disorders, and neuropsychiatry, as well as mental health issues in adults aged over 65. Kieran is also pursuing a PhD at the University of Sydney on time series analysis and brain dynamics during sleep. Also on our panel tonight, we have Dr. Michael Krasovitsky, a medical oncologist at St. Vincent's Hospital Darlinghurst, specializing in geriatric oncology and is also a clinical academic at UNSW. Thank you so much for joining us tonight. And now I would like to pass on to Dr. Kieran.
Hi there, thanks for joining, and thanks for that introduction, both Lauren and Caitlin. Let me get my slides up, one tick. There we go. And I'll just bring up the chat box as well. So yeah, first let me do sort of a second introduction. I'm Kieran Owens. I'm a psychiatrist, and I've got a subspecialty training and interest in old age psychiatry. And Michael and I talked about what kind of joint content we might present to you guys tonight, and we settled on a bit of a tour through different presentations of mood and cognitive difficulties that you might see in late life, and in particular the different flavors of depression that might turn up with the added complexity of older age. And so what I want to talk to you about this evening is firstly a bit of an overview of major depressive disorder. But really the meat of what I want to dig into is a bunch of case studies. Now, I want to make this as interactive as possible. And given that we don't have any microphone access for the participants, I strongly encourage you to type in the chat. So once I get to the case studies, I'm going to throw a bunch of open questions at you guys about what you think is going on, how we might proceed in the case. And yeah, I invite you all to just, put in a stream of thoughts about it. I'll monitor that and sort of respond to what you think is going on in the cases to try and keep it interactive. So, major depressive disorder, how do we define it? I use the DSM-5, the Diagnostic Statistical Manual of mental disorders in my practice. Some people prefer using the ICD classification. The reason I tend towards the DSM in my practice is that it's simply the definitions that are used in most major clinical research trials. Yes, the ICD has a role to play out there, but when it comes to the pragmatic value of diagnoses in psychiatry, a big part of their value, as well as communicating what's going on to the patient and to other clinicians, is actually being able to tell patients something about prognosis and advise them on what treatments may work for their particular situation. And that's why I default to using the DSM-5 generally. So the standard definition in the DSM of major depressive disorder is that you have to have at least 2 weeks of 5 or more of these symptoms, and at least one of them must be depressed mood or anhedonia. And that sometimes catches people out, because you can have people turn up where they deny feeling that sad, but actually if you dig into the way they're living day to day, you find that they're not getting much joy out of life, and things that previously brought them pleasure are really dull and bland. And that anhedonia is a critical one to ask after when exploring the possibility of major depression. And then you've got the range of other symptoms that I'm sure you all know too well, ranging from change in appetite or weight, insomnia or hypersomnia, fatigue, psychomotor changes, impaired concentration, a range of negative sort of ruminatory content, and suicidality, of course. Now, key thing about major depression is it's really common, right? Lifetime prevalence in the estimates from the DSM-5 field trials was about 20%. And over a 12-month period for the older population, so above 65, it's at least 5%. And you could look at pretty much any major chronic illness and you'll generally find a higher rate of depression in that group. Right? We see it for nursing home residents. We see it after stroke. We see it for Parkinson's disease. We see it for oncology patients. It's one of the major factors that needs to be explored when we're dealing with depression in the elderly. Of course, they've got more comorbidity, and that often plays into it. Now, sometimes it's the suffering component. There's always going to be a psychological dimension here when we're dealing with depression. But there's also, in some cases, a neurobiology. So in the case of post-stroke depression, there's a literature showing that the closer the stroke is to the frontal pole, the more likely depression is to occur after a stroke, for example. So there's a bit of neurobiology in there as well. And another interesting phenomenon is that a number of studies report psychotic depression occurring more frequently in the elderly. That's certainly my experience, especially when I've done inpatient old age psychiatry work. That I've been on small wards where at times about half of the patients are in there for psychotic depression. So that is something that we see quite a bit of in late life. So the DSM-5 criteria, they're the gold standard for diagnosis. We do not have biomarkers that are defining of major depression. I'm skeptical of that endeavour, partly because my sense is that major depression is quite a heterogeneous phenomenon. And I think it's unlikely that there's a single biotype that defines the syndrome. But who knows, I might be surprised in the future, but that's my gut. So applying the DSM criteria or the application by an expert, whether that's a GP or a psychiatrist or an oncologist, that's the diagnostic standard. The investigations that are recommended by the College of Psychiatry include a bunch of standard bloods that won't come as a surprise to you. ECG is generally a good idea, especially in older patients. And the main reason for that is the potential for cardiac toxicity with a number of antidepressants. A prominent example of that being the tricyclic antidepressants, which aren't as commonly used first or second line these days, but they're still in use. And of course, you could get a development of a heart block, among other issues with those. And specifically in the older population, so if we're looking at 60 or 65 plus, generally cognitive testing and an MRI brain are recommended as part of the workup for major depression. Now, differential diagnoses are broad. This is not exhaustive, but just some important examples. I break them into psychiatric, neurological, and medical differential diagnoses. So on the psychiatric front, everything from grief to adjustment disorder, personality disorder, substance use, bipolar disorder, PTSD is another one I don't have listed there. Common neurological conditions like delirium, dementia, etc. feature. And then there's a number of medical conditions, nutritional deficiency states, inflammatory states, endocrinopathies, malignancy, etc. Here's a sort of overview of the approach to treatment of major depression. This is how I generally conceptualize it, breaking it into lifestyle, psychotherapy, medication, and brain stimulation-based treatments. And really for most patients presenting with major depression, I'm making use of the first three categories. There are many cases where you don't need to make use of medication, and I find a lot of the interest for me in managing major depression is actually the complexity of sequencing all of these things and tailoring them to patients. There are many more medications than what I've actually listed here, and I've found that compared to the remission rates after multiple steps of treatment that were reported from major studies in the 90s, in my own clinical practice, I feel I see better results than I would expect from those studies. And I think part of that reflects the fact that we've got several novel treatment classes since that research was done looking at sequenced treatment of depression. The decision about whether or not to use medication is often a tricky one. I generally lean towards drawing on medication when there's a moderate to severe depression in a patient that I'm seeing. But there are definitely some standout cases that I'm sure you encounter in your own practice where lifestyle is clearly at the center of it all. I think of, this is getting out of the old age territory, but, a classic presentation would be a depressed younger person who's just recently left high school. They've not worked. They're spending 12 hours a day on social media. They fall asleep anytime between, midnight and 4 a.m. They're not getting any exercise. Diet mainly consists of junk food. They might be vaping and using cannabis. A case like that, you really need to dig in entirely, focusing on lifestyle treatment to start with. You're not going to make much progress until you sort out, their sleep and their substance use and their social engagement, etc. But yeah, there's always a judgment call involved when it comes to which particular treatment modality is used. And you might have questions later about, the choice among some of these with the case studies that I'm going to present to you. So what I'm going to move on to now is a bunch of cases. This is the core of what I want to focus on this evening. And given that I'm not able to have you guys speaking to me directly, I encourage you to type your thoughts into the chat as we go. So I'll present each patient's STEM to you, and then throw a number of questions to the group, and then I'll try and respond as best as I can and pick up on some of the things you're thinking about. So case one, aches and pains. This was a 73-year-old woman who was referred to me by her GP for low mood and functional decline. When I met her, she reported a profound low mood that had been present for at least about a month. There was anhedonia. She was really struggling to concentrate, and that was evident in the review. Even having a conversation with her was quite tricky when we first met, and I had to make quite a bit of use of her husband to get all the historical details in that first meeting. She'd lost quite a lot of weight in the space of 1 month, 7 kilograms. And she had delusions of poverty. So she had, and of a lack of food at home. So she had this sense that despite living in a beautiful home in the eastern suburbs with a double fridge stacked with food, that they either had no food in the house or it was all rotting, and was of the belief that they were impoverished and that they'd have to mortgage their home in order to survive. And that wasn't the case at all. She was waking in the early morning most days around 3 a.m. and couldn't sleep after that. And her mood was lowest in the morning. So really sad early on. And that tended to lift towards the end of the day. So a pretty classic depressive presentation. One of the things that stood out to me was that when I talked to her about her recent medical care, she'd been seen and treated by a rheumatologist before the episode of depression came on for a diagnosis of polymyalgia rheumatica and possible rheumatoid arthritis. And so I'm going to stop there and let's see if we can get the chat working. I encourage you to type your thoughts about, is there anything that strikes you here? What would you do next? Is there anything you want to know about this woman, investigations or questions? Let's see if this will work. Yeah, what are the symptoms leading to the RA diagnosis? Fair question. Yeah, so she mainly, yeah, absolutely. Which medications? So leading up to the diagnosis, she had a syndrome of fatigue, some small joint pain in the hands, and pain and aches around the shoulders. And medications, that's the right question. Steroids being commonly used for these particular conditions and being a trigger of depression. She was started on steroids by the rheumatologist. What doses of steroids called mood symptoms? Yeah. So the psychiatric disturbances that we see with steroids are highly dose dependent. There was a particularly good study done on this, I think in the late 70s out of Boston, where they looked at all of the presentations to one of their major teaching hospitals where they were using corticosteroids. And what they found was when they grouped the patients based on the dose, that there was a dose-response relationship in terms of the prevalence of psychiatric disturbance. So once you got to steroid doses in excess of 80 milligram equivalents per day, the prevalence of major psychiatric disturbance, and by major, I mean a really serious depression, psychosis, or mania, was around 20%. And what had happened in this case was that she was not just started on steroids by the rheumatologist, but there was actually a dosing error by the pharmacy. And so when I asked her how much prednisone had she been taking, it was over 100 milligrams a day for the better part of a week. So that was quite unfortunate, but this is therefore a really clear-cut case of a prednisone-induced psychotic depression. So given that we've defined what was going on, what are the next steps for someone with a psychotic depression, this level of severity, triggered by prednisone? What would you guys be recommending as the next step? I mean, she was referred to me. I think that was appropriate to get her to see a psychiatrist. What would you guys do? Yeah, agreed. So the steroids, she needs to come off the steroids. And actually the rheumatological symptoms weren't that disabling, and this psychotic depression was life-threatening. Actually, she fortunately wasn't acutely suicidal, but psychotic states, especially when it's a first psychosis, are particularly high risk. So generally in psychiatry, it's really difficult to predict suicide. For the most part, we can't. But when it comes to a first episode of psychosis, about 1 in 5 patients will attempt suicide. So it's quite a serious situation. So weaning off the prednisone is important, but also because she was presenting with a psychotic depression syndrome, the standard of care is to treat her with both an antidepressant and an antipsychotic medication. So in her case, I started her both on venlafaxine, the SNRI, and olanzapine, the antipsychotic. She didn't tolerate the olanzapine. She had some postural hypotension. She was oversedated. And so a week or so later, I ended up switching her to quetiapine. and she had a fantastic outcome. So within a few weeks of both weaning the prednisone and getting her on this combination of an antidepressant and antipsychotic, she was fully in remission, which was wonderful. I'm just looking at a couple of the other questions here. Just going back up a bit, we've had a question about bright light therapy. Yeah, okay, that's a good question, because that's a fairly new player on the block. So a lot of you will probably have heard of bright light therapy in the context of seasonal affective disorder. And indeed, that's where it's primarily been studied, right? My sister lives in Stockholm, and because her partner's Swedish, and for a good part of the year, she just doesn't see the sun. And so a lot of people, especially in the far northern hemisphere, they get bouts of depression that occur in the winter months. And so for many decades, we've had this body of research showing that morning bright light exposure using a lamp of high intensity, generally it's what we call 10,000 lux. So that's about the brightness intensity you get when you're out in the sun during the day. That's been used for some time for seasonal depression. What has changed in the evidence base is we've now got strong evidence that bright light therapy also works for non-seasonal depression. So there was a meta-analysis on this topic that was published in JAMA Psychiatry just in January of this year, and they pooled all the relevant RCTs on bright light therapy. And they found that compared to treatment as usual, so a first pass attempt at treating depression where you're having a response rate of about 38%. If you added bright light therapy, we were seeing response rates of 60%. So it's quite a big difference. And certainly in the depression space, that's a really significant difference. And so the way bright light therapy is administered is about an hour in the morning after waking of exposure to a 10,000 lux lamp. Unfortunately, they're called SAD lamps. SAD stands for seasonal affective disorder. It's not just a morbid joke. But yeah, if you search, you can get them. They're really cheap, 20, 30 bucks on Amazon. You can get a 10,000 lux SAD lamp. And it's a nice augmentation option for treatment of depression. And there's another question, good question. What happens when people have to have high dose pulsed steroids? How can you prevent? Yeah, I'm not aware of there being a study on the prevention of psychiatric disturbance with prophylactic administration of antipsychotic medication. I imagine that probably would work. I would expect an RCT to probably give a positive result if that were ever done. Generally, what happens in practice is if someone is having high dose, say, pulse methylpred or something like that, the treating team just needs to be really watchful for psychiatric disturbance and then have a low threshold for either treating that, if they're confident to do so, with typically an antipsychotic, or getting psychiatry involved. We don't, to my knowledge, have good RCTs on the treatment of these steroid-induced mood states. But we do have case series, and in general, it seems that the use of antipsychotics is effective. Put up the nose. Okay, yeah. So I'm not aware of that light therapy used up the nose for Parkinson's. That's not one that I'm aware of. Now I'm going to move on from this case. So just a couple takeaways. Firstly, as I said, major psychiatric events occur in about 20% of patients on high doses of prednisone or other corticosteroids. For psychotic depression, antipsychotic and antidepressant in combination is the standard of care. And one thing I didn't properly touch on in this case is she could well have been an inpatient. I've got a pretty low threshold for admitting people with a psychotic depression. They are really high risk. The thing that allowed me to get away without doing that for this woman was that she wasn't suicidal. She was still eating and drinking, so she wasn't acutely medically compromised. And she had an amazing husband who wasn't working, really doting, was able to just be her carer, and kept a line of contact open with him to escalate to me if needed. And fortunately, we pulled it off. But a more conservative approach would have been to admit her, and I'm sure some psychiatrists would have done that. Now, another case 2, melancholic features. So this was actually someone I saw during my training as a registrar. And this gentleman, 60-year-old man, lawyer and academic, he turned up with to emergency with low mood. And he'd previously had a major depressive episode about a decade before that had been treated successfully with ECT. And he wanted the same, right? So he turned up saying, I think I'm depressed. I think I need ECT. I want expedited access to ultimately a private hospital so I can do that. And so that kicked in a pretty rapid assessment by an experienced mental health nurse in the emergency department. He was seen by one of the junior medical officers who medically cleared him. And his presenting symptoms were several weeks of low mood, anhedonia, couldn't concentrate, psychomotor slowing, fatigue, weight loss. So a pretty classic set of depressive symptoms. He was admitted to a psychiatric emergency care centre where I was the registrar. And I ended up reviewing this gentleman as part of the admission and just going back over some of the details. And one of the things that struck me in talking to him, for someone who was so well educated, he was really struggling to converse. And when I did a neurological exam with him, even basic motor commands were really difficult for him to follow. And curiously, he had asymmetric motor findings. So he was quite rigid, in particular in his right upper limb, and had marked hyperreflexia on that side. So just a little tap with the fingers would elicit quite a brisk reflex. So what's the next step for this chap, having just come from ED to a psych ward with these motor findings? Yeah, look, MRI would be great. CT's quicker, but I agree. Ultimately, this guy needs an MRI. If you could get it immediately, I would. But in that setting, just for the practicality of speed, CT is what I requested. But yeah, absolutely, you need to jump to imaging for this guy, and he really should have had it in ED. But that's okay. We've picked up the issue. Let's see what's there. This was his CT. So what are we looking at? Michael, you're allowed to comment if you want.
Can I speak?
Yeah, go for it.
So there's a large left-sided frontal lesion with rim enhancement, vasogenic edema, effacement of the ipsilateral ventricle, mild midline shift superiorly, with some internal decrease in signal, possibly a hemorrhage or necrosis.
Yeah, wonderful. Would you give him electroconvulsive therapy, Michael?
I would give him at least 8 milligrams BD of dexamethasone, which
Yeah.
everyone will be upset with me for,
No.
and refer him urgently to a neurosurgeon.
No, I agree. That's exactly what happened. So I called the head of ED, got him in a resus bed. They gave him dexamethasone and he was admitted under neurosurgery. So yeah, this poor gentleman, he in fact had a glioblastoma, a multiforme. He had surgical resection and survived about a year before passing away, unfortunately, from this illness. And so I guess the catch, what tripped people up here is he'd been depressed before and he'd responded to ECT before, but someone who has a history of major depression can still get organic depression. So that's a bit of an easy one to trip up on. And neuroimaging has much higher yield in late life depression. When you're presented with someone, say, in their 20s and they're presenting with depression with no sort of red flag features like this, generally you don't need to do neuroimaging, but the yield is much higher in the older cohort, and really 60 plus presenting with especially with their first depressive episode or with any red flags, they should be having neuroimaging. And also, in cases of treatment resistance, right? You might have someone with a well-established depression and you're just going through, the standard treatments that have worked for them in the past. But if you're not getting any success, at some point neuroimaging should be done in older patients. Okay, third case. They make me worse, doctor. So this was a 93-year-old who was referred to me, my GP, widowed. And she deteriorated following hospitalization for discogenic back pain, where she'd been started on a range of medications, including prednisone, tebentadol, and alprazolam. And she was still on a good dose of all of these, actually, when she saw me. She did satisfy the criteria for major depression, and she'd been depressed in the past. But she had a history of recurrent, quite bad SIDH with hyponatremia around, let's say, 116, something like that, millimoles per litre. And that had occurred with SSRI medication, SNRI medication with agomelatine. I cautiously tried a few medications, starting with ones that I deemed less likely to precipitate hyponatremia, and she didn't tolerate anything. So in every single case, there was either in the short term, the emergence of delirium or unsteadiness with falls. So pharmacotherapy just wasn't workable. Any thoughts on what's going on or what the next steps might be for a case like this? So I'll start you guys off with something which is she's on, way too much high risk medication for one. And polypharmacy really was one of the, absolutely work on the benzos and opiates. And so that was, one of the major goals right from the start with her was gradually weaning those down. That was tricky. And, she was one where even with little adjustments of the alprazolam, she was descending into a state of panic and insomnia, getting really erratic, difficult to manage for the family. Radiofrequency nerve ablation, yeah, not a bad idea. I mean, that's out of my expertise, but yeah, certainly other pain management strategies were worth thinking about. For what it's worth, we did actually get her off of tapentadol within, I don't know if it was within the first couple of months, and she was able to tolerate that without a resurgence of pain. So ongoing pain wasn't a major issue in the end in this case. But yeah, in the end, it wasn't too hard to get her off of prednisone and tapentadol, but the alprazolam was the one that was really sticky. And yeah, I agree. Those, what was the dose of prednisone? Yeah, the prednisone was at the lower end, so it might have been max 25 milligrams, and then she was already weaning at the point when I saw her. So yes, a steroid-induced mood state was a possibility, but I thought it was less likely given the dose and given her history of depressive illness. No urinary symptoms. Imaging, and I won't go into these details, but imaging, if anything, showed that there was probably an underlying Alzheimer's type process. So she had quite bad hippocampal atrophy, and with that, fuzzy Kush grade 2 white matter hyperintensity, so a moderate level of chronic microvascular ischemia. So, a standout in this case is that treatment intolerance is a major issue in elderly patients. SIDH, confusion, falls are pretty high on the list. They occur frequently and they can be really dangerous. They can be life-ending. And it's important to distinguish between treatment intolerance from treatment resistance, right? I couldn't actually successfully try this woman on any pharmacotherapy. She actually ended up responding pretty well to TMS, so transcranial magnetic stimulation. So along with the weaning of the benzos and the opiates, which I totally agree was needed in her case, given the extent of her symptoms, I ended up referring her to a provider nearby who did TMS, and that made quite a difference. There was unfortunately a relapse after that I won't go into, but in that initial pass, TMS was quite a helpful therapy for her. And TMS has some downsides. It's expensive, it's inconvenient, and the physical access can be an issue for the elderly. But the safety is, in my view, better than with medication. So if they can afford it and they can physically get there on a regular basis, because TMS occurs most days of the week, typically you do it every day, Monday to Friday, or at least 3 times a week. If they can at least make it there, it's very safe and is a good option for cases like this where they're not tolerating medications. Case 4, wasting away. So we've got an 80-year-old male who was referred to me by his GP with low mood, had a classic set of major depressive disorder criteria with severe symptoms. What was unusual here is, so I'll come back to that a little later. Thank you for that question. So what was unusual here was that he had 12 kilograms of weight loss over a period of about 6 months and drenching night sweats. So he was actually changing his sheets every night. I did start him on some antidepressants in spite of those red flag symptoms, and he had a partial response to the addition of bupropion to some sertraline he was already on, but he was still quite depressed. When I first saw him, I ordered a range of tests, which we can talk about, but I'm just wondering, for those who are attending, what would you do if you encountered this guy in your practice? So major depression, 80-year-old, that much weight loss and night sweats. What would you be looking at? Yeah, for sure. Metastatic cancer is pretty high on the list. As a psychiatrist, I don't order lots of CT chest abdo-pelvises, but this is the kind of case where I do. So yeah, in this case, I ordered a CT as well as getting some neuroimaging, and a broad set of bloods, and all of that came back normal. I was expecting that he was probably going to have metastatic cancer, because certainly cases I've had like this, historically, a lot of them have turned out to have lung mets or what have you, but the CT was clear. The only thing that came back was a slightly raised gamma GT. And so given that he was already known to a gastroenterologist, I wrote a letter to them asking that they get involved in the workup and have a think about what might be going on for this chap. And he ended up bouncing between a few specialists for a number of months until he actually ended up at a subspecialist hepatologist who did a CT cholangiogram. And what turned out to be present was sclerosing cholangitis. And he was then put on the treatment ursodeoxycholic acid, and within a week, all of his depressive symptoms disappeared. It was fixed. So this is, I think, a remarkable case of really an inflammatory depressive syndrome. And he was one where once he had that amazing outcome, we then just proceeded to get him off of all of the those medications that I'd started, that I think had buffered him a little bit and helped a bit with the overall psychiatric syndrome. But given how rapid and remarkable that improvement was on the treatment, with the treatment of the sclerosing cholangitis, it just made sense to get him off of the other psychotropics. And so takeaway here is that in late life depression, you want to have a high index of suspicion for secondary causes, especially when you've got red flag symptoms like significant weight loss, psychomotor slowing, unusual symptoms like night sweats. Okay, one final case before I hand over to Michael. This is case 5. What was I saying? This is a more recent woman I've been seeing in my practice, a 60-year-old who was referred by her GP with a several-year decline in both mood and cognition. She satisfied the criteria for major depressive disorder and had symptoms of moderate severity. But in addition to depressive symptoms, she'd really declined in her function. So previously, she'd been operating a private business, making a very good income, respected in the local community, very independent. And then since the onset of this decline, she'd had to stop working. She'd moved in with her sister, was quite dependent on her for even encouragement to shower and attend to some of those basic aspects of self-care. She'd been forgetting names, increasing difficulty using appliances, difficulty conversing. There was some objective cognitive impairment when I first met her. I did an ACE-3 test where she scored 80 out of 100. So the usual cutoffs of concern are at 88 or 82. For what it's worth, for a patient who gets under 82, the likelihood ratio in favor of dementia is actually 100. And 88 still, for a woman of her professional background, is definitely not normal, and quite a high level of functional impairment using this clinical dementia rating scale that I typically use to judge whether someone's at the level of mild cognitive impairment or a mild, moderate, severe dementia. And 9 out of 18 is more at the level of a moderate dementia. When I saw her, she was already on sertraline. I ended up augmenting her with the antidepressant mirtazapine, and that didn't really offer much benefit. What's going on? What are you guys concerned about? What might your next steps be in a case like this?
Kieran, can I ask, did she have any Parkinsonian symptoms on exam?
No, she didn't. She didn't. I did assess for that,
Okay.
and she didn't. Both with that as a various conditions with motor Parkinsonism as a differential, but also anticipating that I might have her on antipsychotic medication at some point and wanting a baseline. So in the chat box, early onset dementia, definitely that's in the mix. And that's one of the big questions here, right? Is this primarily a neurocognitive disorder? Yeah, check routine things. I agree. So she'd had, all of her routine bloods were normal. Vascular dementia is definitely a possibility. So she needs a really good workup for a possible neurocognitive disorder, as well as any underlying medical conditions that might be leading to cognitive impairment. In this case, she'd already had an MRI brain about a year before that I had access to. But for someone this unwell, I would typically repeat that imaging, certainly if I hadn't had anything for a year. So repeat MRI brain showed no interval worsening of atrophy. So it looked pretty good, actually. And this was a case where I thought further imaging was required. And so what I did next was an FDG PET, because she had some features that could be construed as a frontotemporal dementia, especially with the apathy and the decline in self-care and so on. That was normal as well. And this is really a syndrome that you could characterize as a depressive pseudo-dementia, right? And that's a diagnosis of exclusion. That terminology, interestingly, was partly popularized by a paper written by Leslie Kylo, who gave his name to the Kylo Centre at Prince of Wales. So he was an early proponent of the use of EEG in psychiatric assessment and had an interest in some of these old age neurocognitive meet psychiatric syndromes. If you look at the old literature on depressive pseudo-dementia, a lot of them progress to have dementia, right? If you go to case series from the 70s and the 80s. But at that time, the tools they had to assess for an underlying neurocognitive disorder were really limited. In some of these case series, they weren't even using MRI. And so, a normal CT at baseline really doesn't get you that far in excluding an underlying neurocognitive disorder. And so, we don't yet have a good large case series of the prognosis for this patient group when you use the full suite of available tools. But this woman I'm actually going to follow up with on Friday of this week. And she's one where I'm going to encourage her, if she's willing to cop the expense, to do an amyloid PET scan. An important consideration here is that, especially for Alzheimer's dementia, which is a differential diagnosis here, is that both MRI and FDG PET are late biomarkers in the case of Alzheimer's, right? So they're good at ruling in, they're not good at ruling out. So just because you've got a normal FDG PET and MRI brain does not mean that you've excluded underlying Alzheimer's disease. Whereas an amyloid PET, and now we actually have some blood tests that are pretty damn good, that are approaching, sort of 90% the accuracy of even amyloid PET and CSF studies. These tests are now accepted by the Alzheimer's Association as defining of Alzheimer's disease. So this is what's now being used in clinical trials for inclusion and defining of an underlying Alzheimer's state. Now, of course, a negative amyloid PET doesn't fully exclude a developing frontotemporal dementia. And so there remains a need in a case like this to do quite a bit of ongoing follow-up and monitoring of cognition and repeat imaging, depending on a clinical course. But this is a work in progress at the moment for me. But it's possible to have both depression and a neurocognitive disorder. But given that this is a woman who doesn't have any prior history of psychiatric illness, I think if she turns out to have a neurocognitive disorder like Alzheimer's or similar, that's going to be also the cause of the depressive syndrome that we're seeing, rather than major depression. And, I think that's, fails the sort of parsimony test. So look, that's all that I've got. And I am Yeah, she's depressed enough. So the question is, am I treating her depression currently? Yes, I am. I think it's likely enough that this will be a major depression rather than a cognitive disorder, that given her level of suffering, I'm doing that concurrently. Yeah, what am I using? So at the moment, she's still on sertraline and mirtazapine. And what else might I use? The stuff I listed here. So my personal practice is that I work through medications with different mechanism. You know, I don't typically go from an SSRI to an SNRI to another SNRI, you know, so I wouldn't go sertraline and then fluoxetine and then venlafaxine and then duloxetine. You know, all of those really are primarily SSRI or SRI. They're all primarily serotonin reuptake inhibitors. Even the ones that we call SNRIs are weakly active on noradrenaline. And so my personal practice is that I would work through, you know, SSRI medication, possibly mirtazapine, possibly augment with bupropion or with aripiprazole. And there's actually quite a nice study on augmentation of depression in the elderly that was in the New England Journal of Medicine, I think 2 years ago now. The lead author is Lenze, Lenze, and they're looking at, you know, what's the best augmentation option in someone who's already had an SSRI and not responded. And that particular sequencing of treatment studies favored aripiprazole and bupropion as a reasonable option, and the tricyclic nortriptyline is another reasonable option. But I usually reach pretty early for the antipsychotic aripiprazole and at quite a low dose. So there's a meta-analysis showing that the optimal dose of aripiprazole for depression is actually 5 milligrams, rather than what we might use for schizophrenia or bipolar, which is more often, you know, 10 to 20. I'm going to write that question down. I might come back to it at the end if we've got time. I'll hand over to Michael now. But I'll just have a look at the chat through anything I've missed. And if we've got time at the end, I'll come back to some of these other specific questions. Let me stop sharing.
Awesome. Thanks, Kieran. I am going to share my screen, and Kieran, I might, if I can't figure out how to look at the chat at the same time, although I'm hoping I can, I might ask for your help.
Yeah, no trouble. If you've got the toolbar popping up on your screen, there should be a chat button on that.
Oh, fantastic.
And that'll create a little pop-up window.
Me, your right chat. Thanks so much, Kieran. Thanks, everyone. Really lovely to be here. And it's so nice to see all these names of people that I've spoken to or messaged or called or complained to. So really, really lovely to be here with all of you tonight. And I appreciate you spending your Wednesday evening listening to my musings and Kieran's musings. And I'm going to take an ever so slightly different approach and look at individuals with cancer and look at the psychiatric syndromes that individuals with cancer of an older population, of an older age can experience. So we're going to look at 3 case studies, and then I'm going to focus on adjustment disorder and grief disorders when talking generally about acute deteriorations in mental health, because these aren't, I don't think these are considered particularly sexy disorders, but they are very, very common. And I deal with adjustment disorder and grief disorders every day. And I think we probably all do, because these are really universal experiences that exist on a spectrum from non-pathological to pathological, and sometimes distinguishing what's normal and what's not normal is quite difficult. So I want to start with this case. It's of an 82-year-old woman who's previously been well with no significant psychological or physiological comorbidities. She's diagnosed with an early left breast cancer. A biopsy confirms an ERPR positive ductal cancer with a 1.4 centimetre primary. She has a primary resection and lymph node biopsy, and postoperatively has radiotherapy and is commenced on letrozole and aromatase inhibitor. And she tolerates her radiotherapy really, really well. She's actually really cool, this patient. I really like her. And I would routinely see people at 4 to 6 weeks following the commencement of any hormonal therapy. And she describes feeling pretty irritable, really angry about her cancer. I'll come back to this, but that is a really common experience, that women in particular just get on with the job of having their surgery and their radiation and their chemo, whatever it is. But then when the dust settles, that's often when they begin to process what's happened. She didn't feel that her family were giving her the help that she needed. She was finding herself crying a lot when watching movies, and she felt that her thinking was a bit foggy. She was having more difficulty talking to people at work because she was developing this sensation of word finding difficulty, and she was really nervous that she was developing dementia. Her clinical exam was unremarkable. There were no motor signs, no Parkinsonian signs, and no ocular signs. And we went on to do a Montreal assessment, as she had a MoCA score of 27 out of 30. She'd had a CT brain as workup of her malignancy, and there were some minor microvascular changes. Blood tests, including hematinics, were normal. And so these are the differentials. And I think, Lauren, you can do a poll. Is that right? There we go. So does everyone want to pop in what they think could be going on? Oh, I'm told I can't vote, but everyone put in what you think is happening. I think point E is critical. Maybe the husband was actually quite annoying. And if you put your answers in, I can't see how many people have put their answers in, but maybe we'll close it in a second or two, Lauren. And Kieran, I can't see what people, oh, there we go. Okay, so 48% of people said an adjustment disorder, 8% of people said emergent depression, 32% said aromatase inhibitor, mood and cognitive toxicity, 4% said cognitive impairment, and 8% said normal process. Maybe the husband actually was quite annoying. And to be fair, he was actually, but that's quite beside the point. And so number one, people have thought is adjustment disorder. Number two is AI, aromatase inhibitor toxicity. And I actually think they're both correct. But the primary issue here was actually the tablet that I gave her. So aromatase inhibitors, I'm sure you all can think of patients you're looking after who are on letrozole, anastrozole, exemestane, or tamoxifen. Aromatase inhibitors are letrozole, anastrozole, and exemestane, and estrogen receptor mixed agonist and antagonist therapies are tamoxifen and another drug called teremorphine, which we don't use all that much. And essentially, they deprive women of estrogen. And it does so mainly through inhibiting the aromatase enzyme, which takes precursor steroids into estrogen and testosterone. And estrogen, it turns out, has a very, very important role in cognitive function. It enhances our cholinergic and glutaminergic systems. It is critical for neuronal survival, differentiation, and plasticity. We know it's important, particularly for overall neuronal function. And it has, of course, cardioprotective mechanisms. The point of some controversy whether aromatase inhibitors do in fact cause mood and cognitive toxicity. And I've mentioned just a couple of the studies here, and this is way too much detail for anyone to really know, but to really worry about. But essentially, early studies suggested that there was not a difference between anastrozole and placebo. We know that tamoxifen, of all of the breast cancer pharmacotherapies, has got the worst cognitive profile, and that's compared to an exemestane and letrozole. We then got later data suggesting that aromatase inhibitors were worse compared to placebo. And suffice it to say, though there is a huge amount of controversy in the literature, as evidenced by the number of studies that show no difference and the number of studies that show there is a difference, my belief is that they do have an impact on mood and cognition. And taking all of those studies together, a colleague of mine, Lucy Hagstrom, did a systematic review and found that the evidence does support an impact of aromatase inhibitors on executive function, processing speed, verbal memory, fluency, and concentration. And I think that's a lot of what this individual was experiencing. And, some people, I think, have the impression that breast cancer pharmacotherapies, particularly oral pharmacotherapies, are quite simple, but actually this is why we see people regularly, because these, what many people think are benign therapies, in fact, do have a very significant impact on mood and cognition. So we actually continued the letrozole. We engaged our patient in a physical rehab program and a cognitive rehab program, which one of the occupational therapists we work with has a specific interest in. Look, I did this. It might be made up, but I do it sometimes, as do my colleagues. I put the patient on an omega-3 fatty acid supplement that actually does have some evidence, and B group vitamins also have some evidence. Suvinade is a supplement that some of my neurology colleagues quite like using. Kieran, I'm not sure if you use Suvinade.
Lukewarm on it. If some of my patients want to do something, and so they, arrange that themselves, but I don't typically recommend it.
No, so I similarly did not particularly recommend it. It seems a little bit magical to me that a drink supplement could improve your memory. Nonetheless, she was very keen to take on a maximalist approach. And at 6 months, she felt essentially back to normal. Now, I can pat myself on the back and think that it was all the things that I did. But in actual fact, this is probably just the natural history of tolerance to an aromatase inhibitor, and what I instituted may not have actually led to a huge difference. Nonetheless, I'm going to congratulate myself. Kieran, do you think about omega-3 fatty acid supplementation? Or do any of my colleagues online think about that?
Yeah, look, there's some evidence for that, and there's a few conditions, including depression and cognition, where it's probably a reasonable thing to try. Certainly in the case, going back to major depressive disorder, I didn't talk about this, but there are some evidenced nutritional interventions that I'll sometimes use with people where they've tried a lot of the other available treatments, or they're really struggling to tolerate medications, and it's at least something we can do to augment their treatment. So one example that has a nice randomized trial in the American Journal of Psychiatry is a really high dose of L-methylfolate. Where L-methylfolate is a form of folate that's particularly available to the brain compartment. And paired with that RCT, where it had a number needed to treat of something like 6 for treatment-resistant depression, which is pretty good, actually. It was paired with a study where they were getting CSF samples from patients with treatment-resistant depression and looking for nutritional markers. And they found that 10 out of something like 30 patients in that study actually had cerebral folate deficiency that wasn't detected in the blood. And so my takeaway from that study is there's probably a subset of patients with treatment-resistant depression, this is probably true in the cognitive space too, who have unidentified nutritional deficiencies. But of course, there's no money in this space because you can't patent L-methylfolate. And so, unless you've got generous NIH grants, which at the moment with the current government in the US we're not getting, you don't see these trials. But anyway, tantalizing thread of evidence. But yeah, there are some nutritional interventions, including B vitamins, I do use.
Thanks, Kieran. And just responding to one or two questions on the Q&A, Bronwyn, very, very happy to share my slides with you, of course. Bronwyn and I have a wonderful working relationship. I hope you all know Bronwyn Gould. She's incredible. And yes, anonymous attendee, I agree, omega-3 fatty acids do have a very strong anti-inflammatory effect. As such, we actually strongly discourage omega-3 fatty acids and vitamin C for people receiving chemotherapy or immune therapy, where very much the goal is to create an oxidant effect. But in this sort of survivorship phase, we do use it. If there's no other questions, we'll move on to Mr. JP. This is an absolutely fascinating case, one of the most complicated men I've ever looked after. So this is a 77-year-old man who had a background of scleroderma, and he really had quite significant scleroderma. He had interstitial lung disease, Raynaud's, calcinosis, esophageal dysmotility, sclerodactyly. I wrote no ILD. That's incorrect. My apologies. He did have ILD, and he also had some ocular complications of scleroderma. He also had a history of prostate cancer, which was treated surgically, as well as a variety of other comorbidities listed there. I note that he'd had thyroid cancer before, and he had some cardiac abnormalities. And when I first met him, he had a MOCA of 24 out of 30, and that's a pretty standard part of our kind of geriatric oncology assessment. He had some LFT abnormalities noted by his GP, and had actually previously been diagnosed with metabolic associated fatty liver disease and alcoholic liver disease leading to cirrhosis, and had been on surveillance, but then moved overseas and had not had surveillance. After his LFTs were noted, he had some imaging organised and was found to have this enormous hepatocellular carcinoma with portal vein invasions, numerous lesions throughout both lobes of the liver, very extensive lung disease, and lymphadenopathy above and below the diaphragm. And a biopsy confirmed hepatoma with an alpha fetoprotein of about 370,000, which is very impressive. He was pretty asymptomatic, and the standard of care for first-line hepatoma treatment is immunotherapy and a vascular endothelial growth factor receptor inhibitor, bevacizumab. And after discussing the case with his rheumatologist and respiratory physician, we decided to give that a go. So we started atezolizumab, which is the immunotherapy, and bevacizumab, the vascular endothelial growth factor receptor inhibitor. And he had this incredible biochemical response. His AFP dropped to about 400. And in fact, it was so rapid, his AFP drop, that I kind of scrambled after a week or two, noting how substantially his liver was shrinking clinically, to put him on allopurinol. And I gave him a dose of rasburicase because I thought he was actually developing a tumor lysis syndrome. But before his fourth, which I should say is extremely rare in hepatoma, before his fourth cycle, his wife described his cognition as worsening, and he developed some wandering behaviour, confusion, and a change in his memory. He was also an extremely sweet, gentle soul who had become far more irritable, and his mobility had progressively become abnormal. He'd become a bit constipated, he'd had a couple of falls, and he was having trouble with his sleep. And I redid a MOCA, and it was 7 out of 30. So before we move on, does anyone want to tell me kind of vaguely what's going through your head, what you might want to do, give me just some thoughts. Would interventional radiologists help with freezing hepatoma? So I'll answer that question briefly. So yes, we use interventional radiology a lot for treatment of hepatoma. We don't use freezing techniques. We use ablation, usually a thermal ablation or an alcohol ablation. We use TACE, which is transarterial chemoembolization, or something called SIR-spheres, so selective internal radiotherapy. Cryoablation has sort of gone out of fashion, though still very relevant, but it's probably more been replaced with thermal ablation and radiofrequency ablation. This gentleman really had metastatic disease, and even though we do use local therapies sometimes for hepatoma in the context of metastatic disease, it was really his it was really the metastatic disease that was life-limiting for him. Anonymous said Parkinsonism, which I definitely had up there. Yep, Bronwyn thyroid, agree. And then, yes, and then Susan, would rapid destruction of cancer. That's right. So could this be a kind of tumor lysis syndrome? So I didn't really know what to do. So when in doubt in medical oncology, spend $100,000 on tests. And so we admitted him to hospital, and he actually we found on a kind of more thorough review that he really did have quite significant neuromyotonia. So quite myotonic lower limbs with some fasciculations. And really the primary and kind of glaring abnormality talking to him was these really profound deficits in abstraction. So I would say to him, we used to do this I don't know, 3 times a day. I'm sure the patient got quite sick of it, though I'm not sure he remembered. You know, what's the similarity between water and juice? And people would say, you know, they're things that you can drink. And he absolutely could not form an abstract understanding of how those two things were similar. And he would talk ad nauseum about, you know, how juice was made. And then when I asked him to come back to the similarity, he'd be unable to tell me. He had neuraxial imaging, which was unremarkable. He had some mild electrolyte micronutrient deficiencies, B12 and hypovitaminosis D, which were corrected. He had what we would consider quite normal in scleroderma, a very high SCL70, a weakly positive JO1, and a positive ANA. For what it's worth, he had some GAD antibodies, which are, you know, part of the sort of encephalitis screen, which were raised. And he ended up having an EEG, which demonstrated some non-specific slowing, and a CSF that demonstrated raised protein and oligoclonal bands. And he had a very high IgG, which sort of made us think, okay, well, there's something immune going on in the CNS. And in fact, this chap was diagnosed with something called Morvan syndrome, so immunotherapy-associated Morvan syndrome, which is a very complex, typically autoimmune syndrome, typified by neuromyotonia, insomnia, rapidly progressing cognitive deficits, disorientation, irritability, and dysautonomia. And he, in fact, ticked almost all of those boxes. And someone's just said limbic encephalitis antibodies have 40% false negative rate if done in Australia due to the methods used. Need live cell-based assays, so could be missed. Yeah, so I don't think I can comment specifically on that number, 40%, but you're absolutely right. Serum limbic encephalitis antibodies have, I actually would have thought, a slightly higher rate of false negatives, which is why we always need to do a CSF for these patients. And yes, a neuroimmunologist. I'm not disagreeing with you. I'm sure my neuroimmunology colleagues would be completely on top of it. And I was very lucky to have a colleague working with me for this case, Jennifer Massey. And so this patient was treated with 3 days of high-dose IV methylprednisone. He also had plasmapheresis, which we're increasingly using when dealing with immunotherapy toxicities. We gave him some intravenous immunoglobulin and also 2 doses of rituximab. So really an extremely intense intervention. And that was because we didn't really see enough of an improvement on methylpred. IVIG is pretty easy. We chucked that around without much hesitation. But the decision to plasmapherese and then give rituximab was essentially based on, you know, the severity of his illness. And as you can see, he kind of gained 3 to 4 points on his MOCA every week. And the most recent MOCA when I saw him in clinic last week was 24. And he remains pretty stable. So we're gonna come to this. I might just answer 1 or 2 questions. So, is this a demyelinating disease? No, it's not a demyelinating disease. Actually, it is somewhat analogous to just a severe neuroinflammatory syndrome. Kind of increased inflammation around the myelin sheaths and within the neurons, leading to decreased neuronal function. Again, the comment about encephalitis antibodies, yes. Yes, so the side effects of plasmapheresis. So plasmapheresis is an absolutely fascinating intervention. For those who are unaware of the practicalities, essentially you put a VAS cath in, and you then you've got an afferent and an efferent tube. You take blood out, you run it through a plasmapherese machine, which attempts to remove antibodies within your plasma. It's then mixed with IVIG or with cryoprecipitate and re-delivered directly into the bloodstream. the main side effects of plasmapheresis, in fact, are metabolic. So patients can get quite profound hypocalcemia, and so we need to check the calcium as we go through. You can also get bleeding disorders because you need to be heparinized through the machine. And for some individuals, there can be a relatively, particularly when used in this context, and a pretty significant behavioral change. That's usually very short-lived, though. And then how would you stop side effects of pred doses this high? And so, my poor registrars know this. Every person that goes on high doses of prednisone in my field, so that's anyone more than 4 milligrams per day of dexamethasone, goes on prophylactic Bactrim, vitamin D, and a proton pump inhibitor. And we, as I've written in the chat before, for other syndromes associated with steroids, we really do just manage them supportively. So we've got a very low threshold to commence people on insulin for their hyperglycemia. A lot of our patients get a benzo to help them sleep at night. My preference is usually to give individuals olanzapine, which I use a lot of in my line of work. And so certainly olanzapine to decrease the insomnia, benzodiazepines to help with anxiety. We pretty aggressively treat blood pressure and sugars, usually with a calcium channel blocker and insulin, respectively. And we obviously just monitor closely for other toxicities of high dose steroids, acute pancreatitis, etc. So I want to talk a bit about immunotherapy-associated cognitive, psychological, and psychiatric syndromes. So this is a kind of developing field, but becoming much, much, much more common because we use immunotherapy so much. So immunotherapy has become the cornerstone of treatment of a lot of malignancies. It's now used in head and neck cancer, lung cancer, some rectal cancers, some colon cancers, bladder cancer, kidney cancer. What am I missing? Triple negative breast cancer. I think what else there is. It's used in a lot of cancers, and there are a variety of different types of immunotherapy. So anti-PD-1, which is pembrolizumab and nivolumab, anti-PD-L1, which is toripalimab, camrelizumab, atezolizumab, avelumab, durvalumab, anti-CTLA-4, ipilimumab, and LAG-3 therapies for melanoma. And essentially what I tell my colleagues is think of anything add itis to the end, and that's a possible toxicity of immunotherapy. And that's based on the fact that the mechanism of action is inflammation. So within the central nervous system, all of the issues listed there, polyneuropathies, myasthenia, and then muscle abnormalities. And there's an increasing understanding about the role that immunotherapy can have on mood. And that actually, from a pathophysiological perspective, is really interesting. And I know that's something I've discussed with some of my psychiatry colleagues, and I think probably lends weight to the hypothesis that there is an immune basis to many psychological and psychiatric syndromes. And so we are increasingly noting individuals experiencing depression, often a very melancholic style depression, anxiety, mania, incident psychotic syndromes, cognitive changes, and memory abnormalities. But I think critically, this is a diagnosis of exclusion and is treated supportively either with immunosuppression or immunomodulation. And coming to the other questions that we've written, how do you stop mood symptoms on high-dose prednisone? Or you can't. You can't prevent mood symptoms on high-dose prednisone. I use high-dose prednisone a lot, unfortunately. And I have to say, the most common mood disorder that I identify is anxiety as a result of that. We can treat anxiety quite comprehensively with second-generation antipsychotics, benzodiazepines, or and cognitive behavioral therapy or psychotherapy. For acute psychotic illnesses, that's much more difficult, and mania as well, much more difficult. and I would be seeking assistance from my psychiatry colleagues in that instance. Obviously, we try to get the dose of steroid down as much as we can. We add steroid-sparing agents like methotrexate or mycophenolate in quite early, and we're often trying to keep things on hold for a certain period of time until we really can get the steroids down. But we feel pretty comfortable as a profession now using antipsychotics, and that is now increasingly being used. Ramona, yes, great question. I think the neurotoxicity was worse because the response was so rapid. What's really interesting about this case, I don't even think I put it in. Oh, yes, I put it in the corner. Was he had such an incredible response to treatment that, so the fact that he had such a severe psychiatric syndrome was in some respects kind of heartening to me, because someone who gets such a bad psychiatric toxicity is going to get really good bang for their buck in terms of their cancer, because what you've got proof of is this hyperactivated, hypervigilant immune system. And so this guy's cancer has been exceptionally well controlled. His AFP has now normalized, and we stopped his treatment because of this toxicity. I saw him about a week and a half ago. He's got no evidence of disease. So all the lung mets are gone. The liver disease is now no longer arterially enhancing. He's the kind of person that may well be cured because he's had such a hyperactivation syndrome. It's very cool, not for him. And then, is mood disorder with steroids in all? And if not, is there a predisposition for it in some only? I might hand over to Kieran for that. I can tell you my 2 cents. My 2 cents is no, it's definitely not for all people on steroids. Kieran?
No, I mean, so I think I mentioned earlier that it's very much dose related. So the study that looked at this, they found that those receiving less than 40 milligrams a day prednisone equivalents, 1.3% had a severe psychiatric reaction, by which I mean psychosis, mania, or major depression. Between 40 and 80 milligrams, it was about 5%. And once you got over 80 milligrams, it was around 20%. So it's very much dose related. And there's a question there as well about how long does this last? There was one review, this is old, this is going back to the 80s, but they looked at all the uncontrolled case series, and they found most cases you had recovery within 2 weeks and about 90% within 6 weeks. But these are also cases where they're weaning steroids and typically treating with a second generation antipsychotic at the same time, or back then probably was more first generation.
Yeah, and I would agree with that. I think as someone who prescribes a huge amount of steroids, I do not see psychological or psychiatric symptoms in most of my patients. Although, of course, many patients say they feel revved up and a bit energized and have some insomnia, which for anyone who's been on steroids, will attest to, people on this call, it can be a little bit unpleasant being on steroids. But I guess what we're talking about are those really very high-end toxicities. And so my last case is, I think, also quite interesting. I mean, I think they're all interesting. So this is a 79-year-old woman who had a diagnosis of mild cognitive impairment and thus had no functional ramifications, as is a criterion of mild cognitive impairment. She had had a MOCA in August of 23 out of 30. She'd had no progression to overt cognitive impairment. She palpated a breast lesion, and it was an 8 millimeter. It was an 8 millimeter triple negative breast cancer. Because it was less than 2 centimeters. So for women with breast cancer of triple negative subtype, if it's 2 centimeters or greater, we typically give people neoadjuvant chemoimmunotherapy, but this was under 2 centimeters. And so we decided to go to upfront surgery, and she had triple negative breast cancer. She had some high risk features. And so I offered her 4 cycles of doxorubicin cyclophosphamide plus minus paclitaxel. And that's a very common regimen for adjuvant therapy of breast cancer. I wrote plus minus paclitaxel because the main thing I wanted was to get the anthracycline in, that doxorubicin. So she starts doxorubicin and cyclophosphamide, and she goes okay with the first couple of cycles. And then prior to cycle 3, she tells the nursing staff that she's getting a bit clumsy at home. She's got to turn the sink tap off, and the bathroom became flooded. She was in the bathroom due to diarrhea. She said that she felt less sharp than previously. She'd been struggling with her phone, which was quite new for her, and she'd forgotten to take her steroids after chemotherapy, despite being reminded. She didn't have any attentional deficits in clinic, and her MOCA was 18 out of 30. She had had an MRI brain prior, which demonstrated some bilateral hippocampal volume loss, very marked microvascular changes, and her bloods were basically normal, a hemoglobin of 89. I'm not that stressed about in someone getting chemo. So Lauren, perhaps we could put up the poll again. So these are the differentials. So delirium, depression, progression from mild cognitive impairment to formal dementia as a result of natural history, as we know, about 10 to 15% chance per annum of formal progression. Was it related to her cytotoxics contributing to that progression, or did she have brain fog? We'll give it a second or two more just to answer. What would you do if, so Lauren, we'll stop there. I see there's 2 questions, which I'll answer in a tick. And let's see who said what. I can't see the results actually. Can anyone else see them? Kieran, can you see them?
No, it disappeared for me.
Oh, there we go. Okay, so no one thought depression, 11% thought delirium, 11% thought natural history, MCI to dementia, 44% cytotoxics leading to dementia, 33% brain fog. I think this is so fun. I love a poll. And I'm noting one of the comments by one of our attendees saying patients who have had chemo, especially breast, frequently refer to chemo brain. Yeah. So incidentally, actually, this person had a delirium. So her stool demonstrated Clostridium, or what we now call Clostridoides difficile. She started some vancomycin, then everything was fine. But that wasn't as good as what I wanted to talk about, which is chemotherapy-associated cognitive impairment, or what is often called chemo brain or chemo fog. Now, this is the most absolutely fascinating syndrome, and in fact, has received a little bit more funding after COVID, because long COVID and COVID brain became so widely understood that there's now been a push to understand these sort of chronic cognitive changes from chemotherapy. I've put a definition up there for you, but I guess I want to highlight it really is a diagnosis of exclusion, and it's thinking and memory problems that may occur before, during, or after cancer treatment. Classically disorganized behavior, thinking confusion, memory loss, and trouble concentrating. It can be caused by cancer or by cancer treatment, and it can be caused by conditions relating to the cancer, and it can be short or last for a very, very long time. The symptoms based on the literature are impaired memory, primarily immediate recall and verbal recall, concentration deficits, executive function deficits, and truly what patients describe as fogginess or a cloud. And there's lots of mechanisms for it: direct neurotoxicity, a neuroinflammatory response, hormonal aberrations, concomitant mood disorders, immunosuppression. There's some data about epigenetic reprogramming. Sorry, moving tabs. So for this individual, we adjusted the dose of her anthracycline. For some chemotherapeutic classes are more neurotoxic than others. And so for some, if this patient had been, for example, on docetaxel cyclophosphamide, we would have changed it to doxorubicin cyclophosphamide, because taxanes are really very cognitively affect cognition greatly. We spoke to her about memory aids. I encouraged her to do the evidence-based things to help with her memory, such as music and language. She had a dog, and I think honestly, if Pfizer could put pets in a pill, they would be very, very, very wealthy. Getting her out of the house every day and socializing with her friends while she walked around Centennial Park was part of her treatment. We spoke about sleep hygiene. We got her family and friends involved, and in the end, she actually did some private cognitive rehab. We prescribe mindfulness meditation a lot. It's really very evidence-based. So I'm aware of the time, so I'm going to just run through this. Kieran, I actually can't see the time on my computer. I can see it on my watch. Do I have 3 minutes left?
So we've got 5 minutes and then it's going to cut off. So 8
Right.
to 5.
I'll be so quick. So I want to highlight that adjustment disorders are extremely common. And this is not one of the sexy disorders that we talk about when we think about psychiatry, really, but we all see this every single day. This is just a universal part of our job. And I thought I would put in the formal definition, though I'm not quite sure how useful this is, but the development of emotional or behavioral symptoms in response to an identifiable trigger within 3 months of the onset. As with many psychiatric illnesses, it's clinically significant, either impairment in function or marked distress, not associated with another mental disorder, and not bereavement. And it shouldn't last for more than 6 months after the termination of the event. And there are other subcategories within it. There are interventions for adjustment disorder, largely psychological and largely based around the acceptance and commitment therapy framework. We do use antidepressants for severe adjustment disorder and often using an SNRI, though I've learned from Kieran that perhaps we should be thinking about these as just SRIs. And of course, exercise, psychoeducation, and reducing alcohol. Final thing, I think grief is one of the most fascinating syndromes in the world. To even call it a syndrome is a little bit melodramatic, perhaps, but I just wanted to put 5 terms up here about grief disorders. So, bereavement being the death of a loved one, grief being the response to that loss, mourning, fascinating definition there, the process of adapting to a loss and integrating grief. That is accepting finality and consequence, restoring the capacity to thrive, and re-envisaging the future for the possibility of happiness. Acute grief is associated with impaired functioning, but prolonged grief disorder, as I've written there, is a much more complicated syndrome. Acute grief involves our distress from the separation, and the second component is related to trauma and stress. There are some symptoms listed there. And what I wanted to highlight from an older age perspective is that there are certain symptoms of grief that are more common in older individuals, and that the main one there is visual hallucinations. Those are typically egosyntonic rather than dystonic, so more pleasant visual hallucinations, and it can occur in up to 50% of people experiencing grief, more common in older individuals. And as part of acute grief, individuals can also develop cognitive disturbances. Look this up. This is prolonged grief disorder and is a really, really fascinating syndrome. There are differentials for that: unipolar major depression, anxiety, or PTSD. And you can see that the rates of unipolar major depression following the death of a loved one is 22%. And if it's one's child, it's 1 in 3 people. Anxiety disorder is about 25 to 27% in widowed individuals, and PTSD around 10%. So complex field requiring a thorough assessment, and I'm so sorry I've run late, but that is all I wanted to say. I put my secretary email up there, but I'm obviously very happy to give my actual email. I'm happy to comment or do anything. I might just, for what it's worth, I might leave up my slide about the definition of prolonged grief because it really is very fascinating. Now, let me answer some questions. What would you do if patients needed treatment and didn't want to come for more treatment as melancholic, irritable, anxious? so very difficult, of course. You can't. I mean, if the individual requires assessment and management in a mental health facility, there are of course options for the management of that through the Mental Health Act. One would never give chemo to someone under a Mental Health Act for a range of legal and ethical reasons. It often is related to getting the family more involved, in my experience, and particularly getting a carer to help bring individuals to their appointments. Of course, if people are really crook in the community, we also often talk to the acute care team. If someone was going through high dose steroids, what do you do for bone density? So if people are on steroids for a very long time, they of course all get bone mineral density scans. The evidence suggests that you are allowed a couple of years on steroids before a substantial detriment to your bone health. But we do use bone moderating agents quite early, and there's definitely evidence for adjuvant zoledronic acid in breast cancer. So we do use bone protecting agents quite quickly. TNF alpha inhibitors are sometimes used for immunotherapy associated toxicity. So sorry, the question there was, why don't you try TNF alpha blockers? So we do. That's the standard treatment for immunotherapy associated colitis. So we use infliximab as our first line therapy, and then vedolizumab as our second line therapy. We also sometimes use infliximab for cardiomyositis if we don't use another drug called ruxolitinib and abatacept. So we do use TNF inhibitors. What can we do for older patients who have falls or can't live independently and have depression as adjustment disorder going into a nursing home? Kieran, great question. Do you have any comments about that?
Yeah, that's a complex one. I don't think I can give a quick one easily to that. It really needs a thorough assessment in the first instance to define exactly what's going on. You know, if it's a major depression versus an adjustment disorder, you're going to take a very different approach. You know, falls as a part of the STEM implies greater risk when using psychotropics, right? Really, everything I prescribe carries a risk of falls. And in the case of someone old enough and frail enough to be in a nursing home, that can end their life, right? They fall, they have a NOF, and then it's game over. So I'm generally very careful with frail elderly, especially with a history of falls. And I'd start with very low doses and go slowly if it's indicated for something like a major depressive episode. But yeah, I guess the other thing you're hinting at is this difficulty of actually going into the nursing home and that change in self-perception, the social isolation, the indignity of it. And so, you know, we sometimes talk about a demoralization syndrome that can occur in those cases as opposed to a major depression. And I think, you know, if the sense is that's what's going on, really it's then about social inclusion and a sense of purpose and meaningful recreation, physical activity, that kind of stuff. So I'd heavily weight psychosocial interventions in a case like that.
You do a lot of CTs. If you need to look for a tumor or site presentation, yeah. So so that's a really, really great question. And interestingly, an article was sent to me just recently, which I'm gonna bring up, and so I can properly tell you where I'm bringing this from. We can do MRIs, definitely. There's no evidence for whole body MRI scans for cancer surveillance. That's something I get asked about a lot. There are private practitioners, one kind of semi-famous one in Queensland, who feels that she, you know, is supportive for people with cancer and does order whole body MRIs, and that has some complexities. We do use MRIs though for younger individuals. So for pregnant women with cancer, we typically use MRI chest and MRI pelvis and abdomen. Do you at all use psychedelics? Not personally anymore, but I have no problem with psychedelics. Look, so there's really interesting evidence about psychedelics, and I think in five to 10 years' time, psilocybin is going to be one of the cornerstones of treatment of existential distress in cancer. there is already evidence that ketamine and psilocybin can assist with the very real syndrome of existential distress for individuals undergoing palliative care. And we have a number of patients that use their own psychedelics. And I certainly have no problem with that. In fact, I dare say for certain individuals, I would encourage that. We don't prescribe psychedelics at the moment. I am very open to the idea of patients using psychedelics and very supportive of trials of psychedelics particularly in the palliative setting.
So comment on psychedelics. I mean, really the spectrum here is ketamine, psilocybin, and MDMA are the main things that have been looked at. Ketamine is in clinical use in Australia for major depression, less commonly for PTSD, but certainly for major depression, you can access it through private clinics. I've dealt with it a little bit when I did a fellowship at the Black Dog Institute. So I've treated patients with racemic subcutaneous ketamine and with TMS. I'm not wild about ketamine, largely because of the cost, right? So there's no associated MBS item. And so the typical cost of ketamine going through a private clinic is something like $1,000 a week. It's really steep. There are very few people who can afford that. And the reason is that it's got anesthetic properties, you can dissociate, you can have loss of motor function, you can have acute hypertensive reactions. And so if you're going to give someone, whether it's nasal with the Spravato S-ketamine or it's subcutaneous, you actually need to monitor them for a period of time. That's the standard practice. So the staffing cost that goes with actually doing that monitoring accounts for most of the total cost. Instead of referring for ketamine, what I'm increasingly doing, and I should admit this is not something that a lot of psychiatrists are doing, but I think it's got sufficient evidence, is I'm instead using an oral alternative that's also an NMDA receptor antagonist, which is dextromethorphan, which is better known as a cough syrup additive, but it's actually got good affinity for that receptor. And there's now good RCT evidence for that in conjunction with the noradrenergic, dopaminergic antidepressant bupropion, which also has CYP2D6 inhibition, which makes sure that you actually have enough of the dextromethorphan in your system to be active. So patients of mine who've been treatment resistant enough to be going down an NMDA receptor antagonist path, rather than referring them for $1,000 a week ketamine, I've been compounding for closer to a couple $100 a month dextromethorphan to treat them. And in the case of MDMA and psilocybin for major depression, personally, I think it's premature to be a mainstay of treatment. I think we may get there. Australia is a bit of an experiment on the global stage in this space. We're putting our feet forward and giving it a go. I typically wouldn't recommend patients to do it outside of a trial setting. You can access it in the private sector if you've got $25,000 to throw at it. That's the going cost for a course of psychedelic therapy with all the psychotherapy bundled in through Monarch Mental Health. So you can now access MDMA and or psilocybin through them if you've got that money. And a lot of that cost is because you've got, a psychotherapist, nursing staff, a psychiatrist, basically dedicated your care for 3 whole days, but it's pretty steep.
There's probably a few more questions, but we might leave it there.